Hello, Şevket. This is Bektaş. How are you?
Hi, brother. I'm okay. How about you?
How are you?
Fine, thanks. Good to see you. Your colleague is Dr. Kool, yeah? Hello, Dr. Kool.
Hello.
Hello. Can you please introduce your case?
Okay. So I thank the organizing committee first of all before I present my case. I'm very happy to be again here in a CTO Essentials EuroCTO meeting, and I want you. We have a very difficult case here. It was done before and they failed, and we are at the point where they failed. And I need you and Masahisa Sensei's guidance and your guidance, Brother Bektaş, how we can deal with this. Let us first present the case, but I want to also introduce you my team first. We have Ömer and Şeref. I'm doing the case with Şeref, and we have Merve here. And Merve is holding the arm of the patient because there is a bleeding from the radial artery. Our setup is biradial, but somehow the patient is still under oral anticoagulant, so he didn't stop that. And we have to be very cautious here by working. And therefore, we are using biradial approach. So let us first introduce the case and then see what we're gonna do. Okay, please present the case.
Hi, welcome back. I'm Dr. Güneş. I'm a cardiology resident at Medeniyet University, Süleyman Yalçın City Hospital. Our first case, the patient is 75 years old male patient with no medical history of hypertension, heart failure, CRTD, atrial fibrillation ablation, and carotid stent that performed in 2011. The patient complains of the exertional dyspnea lasting for 4 to 5 months and admitted to the cardiology outpatient clinics. For New York Heart Association class 1 is about 2 to 3. ECG show pacemaker rhythm, and for the echocardiography, the ejection fraction is about 30%, apical mid-inferior septum hypokinetic, mid-basal anterior wall hypokinetic, infralateral mid-basal inferior wall hypokinetic, and the myocardial perfusion scintigraphy show ischemia in all segments of the apex and the inferior wall. And the coronary angiography and the coronary completed CT angiography performed, and this is the view of the coronary completed CT angiography of this patient.
Guys, can you hear me? So the problem with this case is, this is an ostial CTO. I hate ostial CTOs because the problem is you need antegrade vessel preparation, and without antegrade vessel preparation, your chance is only just tossing a coin into the air and then hoping that you have the right answer. So therefore, I need your guidance here. We have a CT angio, but the CT angio doesn't help us much. This is and we have also creatinine problems. This patient has renal failure. The creatinine levels are under control now. And for now on, we only used 50 cc contrast. We tried to engage antegradely at least to see the ostium of the RCA, but we couldn't see it clearly. There is some channel maybe, but the engagement is very poor. We don't have any engagement there. And the CT doesn't help us much at that point. And our beginning was therefore retro because this was the only option here. And we didn't take too much views of the patient because this is an ejection fraction 30 and patient with heart failure, previous heart failure history, and the renal failure problems. And with this low ejection fraction, I don't have much options here. So that's a little bit distressing and annoying.
Şevket, sorry for interruption. Can you show your first angiogram, first view?
Okay. İlk anjiyoyu gösterebilir misiniz gençler? So we have only taken this one here. The next one, please. This one here. Okay. So I will update you. We have a good channel there. The next one, please. The next one. And we began this. We have a NRH 0.6 gram in the LAD, and this is another NRH 0.0 gram wire. It's like a SUO wire from the APT, but this is not so soft as SUO, but the tip is 0.3 gram, and the shape retention is the fragility score is a little bit low, so it get not destroyed easily. Can we have the next one, please? And then we have an along 2.6 French microcatheter. It's a coiled microcatheter, and this is my default microcatheter along 2.6, and this is the same wire that we entered. It's a 0.0 gram. Any reach the next one, please? The next one. So we will try to catch one of those septals here, and we were in, but this one we couldn't go. Next one. So I make another curve and took back the 0.6 gram wire because to change the anatomy. In order to change the anatomy, I took the 0.6 gram back. As soon as I went in the septal, I tossed the wire, 0.6 gram wire, into the distal LAD again. Next one, please. And you can see here this 2.6 French coiled microcatheter, a long microcatheter, engaged nicely. Next one, please. And then with this destroyed wire, I had a big two curves. It was a big collateral, okay, I can say that. We were able to cross the collateral and went into the RCA. But this was the easiest part, and now we stuck in the complex part. And I want to show you how this microcatheter is advancing. The next one, please. This is a coiled microcatheter. It's like Corsair Pro, but it's a little bit different. Has a PTFA coverage in the proximal part, and the coaxial, the coaxial support is for me. Maybe I haven't used that much as Masaisa Sensei there, the Corsair Pro, but I feel better with this one when I go very tiny septals, and therefore this is now my default microcatheter. And you see this curve here, we had to torque a little bit and then it goes up very easily. Next one. So it was not a challenging septal, I can admit that. And here we go retro into the RCA. Next one, please. And then we got into the distal cap and made a tip injection. Next one, please. So we have some calcification there, and we have a side branch coming out there, right ventricular branch, and we have no engagement of the ostial RCA. So Bektaş, I need you and Masaya Sensei's advice. What should I do from now on? So next one, we punctured with first with 3 gram any-reach polymer jacketed wire. This is like a gladius, to give you some sense about the wire's properties. And then we changed to Hornet 10, and the Hornet 10 went somewhere out of the vessel structure. And if you can help me from this part of the procedure, I would be very happy.
Okay.
Yeah. Thank you very much. It's so far a nice demonstration for the RCA osteo, right? So we can see the calcium, and we are very happy to see that this challenging case is pretty nicely done so far by your skill as well as good judgment. And today we are very happy to have a lot of specialists here, because sometimes the ostial RCA only cross with a retrograde wire. But if not possible, probably some kind of integrate approach may be necessary at the end. But if there is no other way possible, we have probably a knowledge of the E-card, electrocautery, re-entry. Today we have a specialist for E-card, Dr. Ashwad here. So probably we have all sorts of the technical advice, but if there is one advice just for me, probably I would have changed the integrate system from the femoral, because the radial stabilized not good. So in terms of the 6 French, 7 French, regardless, some kind of the push for the reverse cart necessitates the integrated retrograde wiring. And I believe that the femoral approach would provide the best integrate approach for the ostium. That is one possible advice for me, but I don't know how you take it. Radial is always provide very much poor and steady support. Any comment?
Shevkat, for such case, as a first wire, to reach the ostium.
Yep.
Usually I choose UB3, for example, as a first wire. And after reaching close to the ostium, after that maybe I change it to wires like Conquest Pro 12 or Hornet. But at this time, I'm not sure that UB3 will work or not. And I don't know if you think that there is a capacity to advance a double-one microcatheter to do some kind of parallel wire behind it or not. And we should think about these concepts. And may I ask panelists if you have any comment about this case? Dr. Tarek or other panelists?
Şevket abi kolay gelsin. At this moment, try to carry the catheter, microcatheter, retro-microcatheter, as far as we can to the proximal part, and some Carlino could help us. I think we can do some Carlino from the retro and then take a conquest-like wire and try to penetrate and maybe we can also change our catheter with a regular Judkins. Maybe it can come to the ostium. Anyway, it will show us. Sometimes it works.
At this point, I think we will need definitely stiff wires like CP2 can be done, Hornet 14, or if it doesn't work, maybe we can take Astato. And we have some CT images. If we had a CT co-registered device, it could also help to show us the exact place of the right corner ostium.
Hey, Baktash, can I say something?
Yep. Sure, please.
So the problem here, we have unstable integrated guide, we have ambiguous proximal cap, and we have actually unclear anatomy retrograde. So the problem with the experience, when you push stiff wires trying to get to the ostium, the RCA in that position is actually curving about 120 degrees.
Yep.
We never appreciate that by angiography because we're only looking in two view. So the most dangerous thing now is to use pokey wires and to actually follow them with microcatheter because you're going to exit the vessel. And in fact, this wire is outside the vessel. So what they need to happen now, we need to, some way, to remove the ambiguity of the proximal RCA. And you know for sure that the tip of that microcatheter is in the true lumen. The only way to do it, either to do Carlino after you embed it, so you can actually stay in your vessel, or you take a polymer jacketed wire and you knuckle it all the way down to the aortic wall. And now, and only now, you can actually be 100% sure that you're staying inside the vessel. Otherwise, you're gonna exit the vessel. It's not gonna be a big deal if you exit the vessel because they're low pressure and it will shut down, but you're gonna fail in the strategy. The other thing, the integrate guide is really miserable here. I think from the groin, 8 French guide, GR4 sometimes, because that's the only way you can control it, and then you poke at it. Thank you.
Baktash, can I make a comment? Baktash?
Please, yeah.
So, a question and a comment. The case was nicely introduced. My first question was, I understand this is a repeat attempt, and I never really understood what was the mechanism of failure of the first approach. Did they actually get to this stage and they failed to puncture into the aorta? Because that would be quite useful to know. The second thing here is, I think the retrograde wire is in the architecture of the vessel, and yes, if they can do retrograde Carlinos, get the microcatheter around and puncture into the aorta with a stiff wire, the routine externalization, snaring, etc. But if you're not able to do that, we must not overlook the fact that you can use CART. So if you're kind of puncture antegradely, you need a target. Right now, you don't have a good target. So if you're able to, you've gone through a septal approach, I believe you can get balloons retrogradely. So if you get a balloon to the RCA ostium and balloon it, you have a target to puncture antegradely with a penetrative wire, resolving the ambiguity of the right coronary ostium and hence completing the procedure. And in those kind of situations, as you're at the right coronary ostium, you probably want to use those balloons with longer shafts like the Abbott balloons. They go up to 148 centimeters. So that's something that we mustn't overlook, the use of CART.
Bir yeri görsem yeterli benim için.
Just one comment. He has a coronary CT. He has done a coronary CT for this right coronary. So a good analysis for the CT, and if he can integrate this result of the CT with the angiography, will help in directing the wire from retrograde, and help also the choose of the guiding catheter, which one to be more aligned with the right coronary. I think here the CT is very crucial in such patient.
They mentioned that CT was not much helpful in this special
This is
case.
a big problem,
Because the course of the CTO was not clearly visible in the CT, as they mentioned in the first of
This
the
is
case,
but something
yeah, of course,
strange,
in other cases, of
because
course, yeah, it's very helpful.
CT should be a good guide in such cases. Also, I would prefer in the retrograde access a more controllable wire rather than a just penetrative wire. So Gaia Next is a good penetrative wire with a better control than the Confianza or the Hornet, because Hornet just a penetrative wire. So a more controllable wire, or as Dr. Khaldoon said, a knuckle wire to the ostium. This is the best way to go to the ostium, starting with the penetration from the distal cap, a little bit dangerous to reach the ostium.
Dr. Firouz?
Yes, I think in this patient we have some kind of calcification in right coronary calcium upper part. At least CT can say that it's aligned with RCA or not, and the distance also we can assess with CT. At the other hand, I do agree with keeping the retrograde micro from this distance, because we should find the loosest part of proximal cap with, for puncturing, and maybe it can help us to be safer, because when we want to use the hard wires, especially as our colleague said, that sometimes origin of RC is not direct, and it can have angulation, and with puncturing where it can make problem. So I think it's better to take time and spend time to finding the loosest part with I think safer wire, like this wire that
I think Bektash, here Rad-Judkins guiding would help more, because Rad-Judkins could be more easier to engage ostium. We don't need any sport, because obviously it will be difficult to puncture antegrately, but at least we have to make sure where is the ostium of the RCA, because we are blind here. Yeah. We have to have some targets somehow.
Totally agree with you.
Yeah, I think CT angio is extremely important in this scenario, but at least we can see how much calcification we have, or if we have any calcification at the ostium. I think it will be great help. For retrograde, I think like Gaia second or Gaia third would be my first choice in this patient. I have to be very precise. I don't want to go subintima. I don't want to go exit of the vessel. So Gaia second will be the best to me here.
Okay, Stefan.
Stefan, yep.
Just have a quick suggestion here. What I like is to do in these osteoid. I totally agree with Cal what he said so far. As much as I love to do radials, transradial now, in this case, going femoral, it's not only the support, it's the fact that your guide will be moving in phase with the breathing. When you're coming radial, it's not moving in phase with the breathing, because the catheters stay upward, and when your diaphragm goes down, the catheter stays up, and it's moving in. So when you don't have any good contact with your ostium, you need to go femoral. That's one principle. Second, here, he knows for sure is in the vessel structure proximal. I would definitely do an injection there, because you want to see, maybe you have a channel, you want to discover what's going on. And then if it starts a dissection, then you go and then you push, and then you make a dissection, and then you go in there. And then you put more contrast. So you define where we need to play, because here you don't know. You want to make sure that you have a vessel structure there. And then from there you can go, and then you can use stiffer wire. Because at this point, you can exit the vessel structure, because you don't know where the vessel is. And the only way to know it here is with a knuckle or with an injection. Because the antegrade, they have to bail out this and go femoral and get an 8 French there, because that's unlikely to work this way.
Okay, Shevkat, you heard all the comments, and you are the captain at the moment. You should make a decision.
I think
yeah,
Carlo has a comment.
The recommendations were well taken. So I agree with the femoral approach, but the problem here is this: we couldn't discontinue the oral anticoagulation, and it was the only patient that we had for today. So therefore, I didn't want to go femoral, and I was very fast here, so this is still an option. Maybe I want with the wire into the femoral artery and make a very clean puncture. After 30 minutes, I try here retrogradely. And regarding the Carlino, the patient had yesterday oral anticoagulation. That's another concern for me, so it limits my options, actually. I like doing Carlino, but it's also in my mind. So the thing is, with the knuckle that you have suggested, I agree. First, I want to go with the microcatheter into the distal cap further into the lesion, and then I will try to knuckle. If it doesn't help, then maybe I will think of making an Carlino. That's an option. And as the last option, I have taken the advice well, so I would go with femoral and try to go at least make an antegrade puncture. So the problem with the ostial RCA CTO is always this antegrade puncture. If you have an antegrade, if you don't have an antegrade puncture, and the problem here is the ambiguity. I don't know how the vessel course is, and if you don't know the vessel course, then you can puncture with a stiff wire anywhere. So, and the previous operator punctured actually into the aorta, not into the aortic vessel wall, and he was not able to catch into the aorta itself. And okay, let us work, and then
yeah, actually you have a fantastic job so far, and as you described, if you keep the knuckle wire just in front of the proximal RCA cap, and then you can narrow down the antegrade puncture point. That is the only way to just focus on the antegrade direction, both the LAO and RAO cranial projection. Confirmation is necessary. Yeah, that's we are advised. Yeah.
And
Okay, thank you very much.
regarding the choosing of wire for antegrade try, in my opinion, always we don't need a stiff wire as a first choice. Right. Because sometimes there are invisible channel, and maybe with a polymer jacket, tapered wire or other kind of wires, you can by the chance enter it. Okay, Shevkat, let us to move to another cath lab, and we will come back to you. Okay?
Yeah. Thank you very much.
Let us show you what we have done. So, luck is this time on my side. So, show us, guys, where we left you. Go back.
Oh, you are into the aorta.
I hope so.
Wow.
So, so next one. Wait. Okay. Yep. So this was the hornet. Go back. Devam. So we did a knuckle with P, any rich 3 gram P, like a Gladius EX, and then we first go with the hornet, and then we carried our microcatheter into the lesion. After that, we did a knuckle. Öncekini göstersene. Bekle. So with the knuckle, reached as far as we could, and here comes our microcatheter going into the CTO lesion itself, and this calcification there, we opted that as a ostium, so it was a marker for us. We were not sure, of course, and here comes the microcatheter going into the lesion. Next one, please. And this is the you see the This is the any reach 3 gram P, and we went downwards, but actually we didn't like this, and we were discussing whether we should Carlino or not. The next one, please. The next one. And then we tried with another polymer jacketed wire. This is a 6 gram P enrich. Then we decided we should puncture somewhere at least to find a chamber. So now this is Hornet 14, and here we actually find the lumen. But now the question is, from what level we have crossed actually into the aorta? Next one, please. And I was still suspicious that we might enter another chamber, because the calcification and where we entered the chamber doesn't align, so they are in different vaults. So I made this curve here, but it could be still another pulmonary artery puncture or something. I was still suspicious. And then we risked to carry the microcatheter into this chamber. Next one, please. So actually this curve here made me feel better, actually. And then with this microcatheter, next please, we went slowly into that chamber. Next, please. Next, please. Wait. Yeah. Okay. Wait. So I think this coiled microcatheter helped us a lot, because we had a calcified lesion and we needed a robust microcatheter. With any kind of braided microcatheter, we couldn't do this, I think. So now, next one, we are in the aorta, and we made a tip injection from here to be sure where we are. Next one, please. And we think we are in the aorta. What do you think? And at least it's, we have blood coming and the blood is red, but it can be still.
So if you go LAO and it's posterior, that means you are in the aorta. You can confirm that. And you go REO, like the PA is always anterior to the aorta. So you just take a LAO, REO, and that will tell you.
Another way, Shefkat, to confirm the position of your wire was that by another wire or a snare or 035 wire. Try via your antigrade guiding. Try to move your 014 guide wire. Yeah, it was another way.
Actually, easiest way is just touching the integrate guide catheter with the guide wire. That is confirmation inside the
or guide wire. Guiding.
Okay, so yeah, that's nice.
Yep.
And
try that one.
And if you push the wire and the wire goes into the lungs, that means you're in a PA. If the wire goes into the descending aorta, that means you're in aorta.
Right.
Yeah, please.
You can even connect your pressure measurement in the microcatheter. So if you manage to register an aortic pressure, you are sure about that.
Yeah, there are good recommendations. Thank you. I'm trying to touch that one, but.
No, you don't have to. You're in the aorta. Don't worry.
Okay, so give me the.
Now you are in the aorta.
Give me the RG3. So, you know, Masaisa Sensei, I have done every complications that has been written in the Birlaki's book, you know, so
yeah,
you can imagine. And the only one I haven't done so far is the pulmonary artery puncture. So maybe I thought that this time I hit it, but fortunately not. So, I'm going with an RG3 and then I snare this out. So there is no other option I can do. And it doesn't matter anymore from which level I have entered the aorta. I have no other option. And if it's connecting, if I create a new carina, I don't care anymore. If you agree with me, I'm gonna snare this.
Or you can advance the RG3 into the aortic root and the integrate guide catheter waiting for just rendezvous. That is Dr. Butner's method. Just inside the aortic rendezvous.
I will snare this.
Yeah, snare is excellent. Yeah.
Hadi snare alalım gençler şu mikrofonu. Şunu alayım da önce. Okay.
Yeah, in terms of the snare, this three loops, tulip snare is most easily
This is
used.
end snare.
Yeah, and
So I will point my guiding catheter towards a narrow space. So it could be the left subclavian, the truncus, and
yeah.
I will try to go into the truncus first. Maybe I can do it also downwards, but
right, and brachiocephalic region as well.
Yeah, but the guiding catheter is not has not the right shape to go into the.
Actually,
so
you can advance the.
Okay, let me try.
Yeah.
Yeah, we can use also right.
Sure.
But let me try first with this one here. Maybe I.
Yeah, radial park portion is a good portion to grab. Yeah.
Let's try. Okay, tamam, evet beraber yapalım. Hadi
So,
gel.
Şevket, why the catheter stays, still in place? The exit site is maybe different than ostium a little bit.
Al geriye, tekrar deneyelim.
Baktash,
Yes, please,
can I make a comment? I appreciate that the retro injection looked like you were in the aorta, but I had a feeling that it's probably traveled in the aortic wall a little bit before exiting. I've been in that situation before. I've transfused and the fact that you couldn't move the retrograde microcatheter with the antegrade guide is suggestive of that. And yes, sure, you can snare this, but it's quite possible that you may be traveling in the aorta. And I think it's not unreasonable to actually use your retrograde gear as a marker, take a JR4 guide and do an antegrade puncture. And now that you've resolved some ambiguity with the RCA ostium, to actually pursue an antegrade approach. That's something, an option. That's a reasonable option as well.
So I want to point this GR4 towards the truncus, subclavian truncus, and I want to narrow down. So we can puncture again. That's another option, but then it comes to the question that whether we should go with the femoral. So, and the stabilized guiding catheter from the radial, it's very difficult here, and I don't want to puncture the femoral artery, so it might be an option to find a better puncture from the, from antegrade. That's a good suggestion, but as I said, with this bleeding tendency, I don't want to go femoral. Okay. Hadi göster yukarı, gençler yukarı gösterin bana. Yukarı gösterin. Tamam. Hadi göster yukarı subklavyene döneceğim, yukarı göster. Tamam, ver şimdi bana snare'i. Snare ver. So I think we have also some kind of an S aorta here that makes us very difficult to go into that narrow space, but I will try my best to narrow the space as much as possible. So let's alabilir miyiz?
So normally microcatheter has to be free in the aorta at this time and should move a little bit. This is very fixed. I think for sure there is a course of aortic valve, I think.
Yeah, sometimes aerial projection might be of help because that sometimes the guide catheter antegrade and the retrograde wire is just posterior. So.
Görelim gençler yukarı. Okay. Yeah, the course also is not in our favor to divert our guiding catheter to manage with our guiding catheter. The only hope, I think that Sheref will go into my loop and then I will catch it. You can go a little bit back. Geri gel istersen. So yeah, this is not gonna help me. Maybe I can push this.
Wire is up.
Aşağı çek. Gösterir misiniz bana?
You have to pull the wire back to the catheter and push it again.
Yep, yep.
You think so?
Yeah.
Aha, ne yaptın? Geri mi aldın Şeref bunu?
Okay, the wire is up, so you passed it.
Yo yo. Snare'in içinde.
Pull,
No, the wire is... Yeah.
pull it more, pull it more, pull it more. Now push it.
Okay. So the microcatheter is also
okay.
squeezed, you know, it's not easy. I think there is an aortic course and we have...
The wire is not moving with the blood. It's just...
Can you advance your snare more?
Yep, yep. And
And
then,
after that, try again.
Okay.
Yeah, perfect. Yeah.
Okay.
It was good, I think.
One safety measure to be done at this point is because when we grab it and we snare, there's going to be the left guides are really deep into the left main. So when you grab this, you're going to suck the guide in and you may have a dissection.
yep.
So one safety approach that can be done, we have a paper that's going to come, it's about that technique. You bring a wire from your EBU guide or your XB guide. You look at the guide coming in to the left main. So what you want to have a wire that floats into your left sinus from the donor guide. So whatever traction that you're going to do from the other side will prevent your guide from intubating at that same moment. So you protect the ostium whenever you're externalizing. So whenever you're manipulating from the other side and try to snare a wire, in order to make sure you're not going to deep seat that guide in the left main, you put the wire from that left guide, floats into the aorta. Then it protects your ostium.
Okay, try now pulling the wire and advance it again.
Şimdi
No.
Al iyice geri al. İyice geri al. Geri al. Şimdi gönder.
The tip of the microcatheter is too much fixed. It's not moving with the blood. That's why.
Because there is a wire in it.
It's outside.
Because there is a wire in it. The wire is fixed.
Hadi. Geri al. Geri al Şeref. Geri al. Gönder şimdi. Gönder.
He injected in it.
Almadı ya. Olmadı. Yok. Boşta. Şimdi dene Şeref.
I'm afraid snare and the retrograde wire in a different space. So the area projection would be highlight those kind
Okay,
of
hadi
distance.
sağ kraniyele gel. So, okay. So sometimes it will take us 30 to 45 minutes.
Right, you are almost 98%. So
I don't want to make it that long.
It should not take you more than 10 minutes. You
Problem
just
is
change the location.
the RG3 is not floating freely, you know.
not going through. So probably brachiocephalic region would be okay, more upper portion.
What do you think, Shefkat, about changing, giving a care, a bend in the tip of the artery, for example, 2 or 3 centimeters from the tip?
I don't think it will help.
So what happened? You're opening the snare without pulling the wire and trying to. You're not going to capture it unless you pull the wire and you push it again to go through the tulip. Pull the wire now.
Nerede yukarı? Geri gönder, geri çek.
Pull the
iyice
wire.
çek. Tamam, şimdi
Okay,
gönder.
now push the wire again.
Yeah, Carl, the problem here is it's very difficult to push the RG3 through the microcatheter.
I know.
So
I like,
it's squeezing.
That's why I like
you
the
know.
R350 is better actually.
Bende R350 var çantamda ya. Okay, I will change for R350 because I want to go out. I don't want to have this friction. So I don't like this friction here.
Yeah, okay. Now try to capture it.
So I will change with the R350.
The other thing what you can do, you can push the wire all the way to descending aorta and go and capture it in the descending aorta.
Yeah, this is another option I'm thinking of, but as I said, we have too much friction here.
Yeah, I know, it's difficult.
I will change with R350. I will take that advice.
And the other option is to come back with the microcatheter.
I have got it.
You got it.
I have got it, yeah. It will happen eventually. So,
Beware.
Okay, great.
Yeah.
so again.
So watch the left guide. Watch the left guide not to go too far.
Yeah. And I need to bring down the safety wire down as well into the LAD.
Yeah. So
maybe I can put another wire into the aorta. Bana bir şey versenize. Bana bir P3 veya enrich 03 var mı orada boşta?
Chef, we have 2 lectures.
Yeah.
We will leave you for a while and we will come back.
I will put a third wire into the aorta just to prevent the sucking of the guiding catheter into the left main.
You record everything in the pictures and show us later time. Excellent job.
Yeah, okay.
Yeah, thank you very much.
Bana şey verin.
Okay, Chef, we will give you 1 more minute and after that we will go for lecture.
No, you can go for the lecture. I'm still doing. I will update you after the lecture.
Okay, thank you. Or first let's.
Yeah, okay, Bektaş, we are finished, but there are some remarks I would like to express here. So, geri gel. Haldun's advice was good. So we lost our position with the RG3, okay? So then we had to snare again. Next, this time I used an R350. I took it from my Magic Bag. So it helped us a lot because it hasn't had the friction, and it was easy to snare that one because it was free inside the microcatheter. Next, we lost our position. We tried to balloon and go with the micro in, and then we wanted to stabilize the system, but it was not possible. Next. Okay, this is the R350. Okay, next one, and we took it out. And you see, this one is good. Oynasın. You see, we had a wire there in the aorta. It was an Enrich 0.0 moderate support wire. And you see, it prevents the guiding catheter engaging deeply into the left main. And this wire helped us a lot in preventing any dissection. So it was a good demonstration. I wanted to share it with you. And then we ballooned after externalizing the R350. And now we are doing the final touch. We stented the lesion. Next. Okay, next. So this is the result now.
Wow.
We were gonna make a furrow at the ostium if you agree. So we have still recoil there, and we didn't want to waste time with IOS or something like that. So we're gonna do a furrow NC at the ostium now.
NC or IVL, which one?
NC.
Well, thank you very much for your phenomenal work. Yeah, it's very much impressive.
Thank you, Sensei. Masaisa Sensei.
Fantastic case, Dr. Shefkat, congratulations.
Okay, I thank you all for your advice and recommendation. It was very fruitful for me, and your suggestions helped me a lot. Thank you very much to all. Thank you.
Thank you very much to you too. Thank you very much. Excellent job.
Okay, now we can go. Yeah.